Hi everyone. A good evening to all of you. And today I thought we will start a new series of classes, like something which is important for your practical purposes. So, as I'm posted in cytology, I thought I will start with cytological topics. So, I thought we'll start on my one of the favorite topics, that is pap smear reporting. So I'll be doing it in parts because the slides are like way too much. So firstly, I'll be telling about the non-neoplastic part and then about the organisms that are seen in the pap smear. And then we will go to the atypical and neoplastic parts. Okay. So to start with, we'll be discussing about the following topics. That is introduction, and then the pap smear procedure, and then the Bethesda system, and then adequacy criteria of the pap smear, and then about the non-neoplastic cells. So as we all know, pap smear was discovered by or introduced by Dr. George Nicholas Papanicolaou in 1928. And before going to the topic proper, you should know that when all the cervical cancer screening or pap smear test has to be done according to the American Cancer Society guidelines. So according to these guidelines, the screening should be started at the age of 25 years. This is the latest guidelines. And then primary HPV testing should be done every 5 years, which is preferred. Okay. So the preferred method is primary HPV testing, which should be done every 5 years. If that is not possible, you can go for HPV testing along with pap smears for testing. That should be done every 5 years. Okay. And if that is also not available, and if only pap smear testing is available and HPV testing is not available, then you should do it every 3 years. Okay. And then if cervix is removed, that is, if the patient has undergone a procedure of removing the cervix or for causes that are not for CA cervix or any precancerous lesions, then no further screening is required. Okay. And after 65 years, if last 10 years test is normal, then also there is no further screening required. So the screening starts at 25 and it is done till 65 years. Okay. Preferred method is primary HPV testing. But if pap smear is also there, you can go for pap smear as well as HPV co-testing. And this is done every 5 years. And if HPV testing is not there, then you can go for pap smear alone as well, but then the test should be repeated every 3 years. Okay. So how is pap smear done? So as you can see, first the patient is lied down in the lithotomy position, and then jelly is applied in the speculum, and then the speculum is introduced into the vagina. Okay, and then we will dilate the vagina so that the gynecologist or the technician or the pathologist who takes the pap smear can see the cervix properly, and then an instrument is used. I will tell about the instruments that are used. So the brush or the spatula is used, and then you will take the sample from the cervical os region. Okay. And then if it is conventional smear, the cells collected over the instrument, that is either the spatula or the brush, it is directly put over the slide. Okay. And then you are brushing over it slightly. Okay. Not too much applying pressure so that cells can be spread. And then if it is a liquid based preparation, then you immerse the brush that you collected the cells into a methanol or ethanol based preservative fluid. Okay. So there are three types of brushes which I'll be telling. So, but in conventional method, the problem is here we take the sample from the endocervix as well as the ectocervix. But the problem is that since you're applying it directly over the slide, you can see over the brush only maybe 20 to 30% cells might be present over the slide, and there is a chance that 80% of the cells are lost on the bristles of the brush used. Okay, so for the pap smear testing, these are the instruments that we use, that is cervical brush or IR spatula, that is which is used since years. And then there is also a cyto brush. Usually cyto brush is used when you need endocervical component also. Uh, if you're suspecting any glandular abnormalities, preferably. IO spatula, you can see the proper shaping of it so that when you insert it into the cervix, this will going into the external os of the cervix, and this you can get a proper transformation zone as well as the ectocervical part. Okay, so this was the thing which which is used also, which was used and which is still being used for conventional smear. But later on, cervical brushes started coming, which is mainly used in liquid-based cytology. Okay. At present, for liquid-based cytology, these brushes come which can be detached from here and which is immersed in the fluid and then transported to the lab for the processing. Okay. This also as per the shape here, it will be the endocervical part and then here ectocervical part, and transformations on should come accordingly here somewhere. And then, as you perform the liquid-based cytology, when you insert the brush, you are supposed to twist it clockwise 5 times, okay, to get the sample. And then to give a brief difference between conventional pap smear and liquid-based pap test. So in conventional smear, as I said, we are applying the brush or the spatula directly over the smear. So you can see there is so much crowding of the cells. Maybe sometimes it will be very dense, sometimes it will be less dense. But it is not uniform. That is what I want to try to tell. But in liquid-based cytology, they form a very thin layer of cells. Okay, so you can see every single cell to a greater detail. And then cell loss ratio, as I said, it can be lost over the instrument itself. 70 to 80% might be present, which we have not spread. And then here the cells are not lost because you're immersing the full brush into the preservative fluid, and then you can know ki it's not only that you will get one slide out of it, the rest of the preservative fluid is preserved. So 100% of the cells are preserved in the solution, and during the procedure only the apt amount of cells that are required to produce a very thin layer of cells over the slide is used. Okay, the rest of the cells will be present in the suspension itself, which can be used to make other slides or it can be used for other tests as well. Okay, and while reading also, it is sometimes hard in the conventional smear. Why? Because if you have seen conventional smears, you know there can be obscuration by blood and mucous substances and inflammation so much, okay, because of the overcrowding, etc. And because of the procedural advantage in liquid-based cytology, the obscuring factors like blood, mucus, lubricant, etc. are not at all present or present in very, very less amounts. Okay. And then cell nature also can change if it is not fixed properly. Okay. Sometimes if we get pap smear in jars which doesn't contain any formalin, which is used to preserve the conventional pap smear, then you will get wide range of air drying artifact on the slide, and which will be very difficult to be differentiated from atypia, and it can cause problems in reporting. Okay. it will be difficult for us to see whether there is any abnormality. But in liquid-based cytology, since it is put into the preservative solution as a procedure properly, the chances of artifacts and fixating problem are reduced. Reproducibility, the specimen cannot be reused after the smear. Once the smear is prepared, it is done. Now you can just use the slide to see again and again or for second opinion, but you cannot prepare another smear from. And even the brush also is discarded because you cannot, once it is taken, then the rest of the specimen is already dried because of the air and it is unusable. And reproducibility of the liquid-based cytology, I already said ki it is the rest of the cells are present in the preservative solution and you can use it to make other slides if you are suspicious more until the term of the validity of the preservative solution. Okay. So recollection should be required if you need the patient specimen again in conventional smear, but here you can do additional tests like HPV test with the remaining cells in the preservative solution itself. So now we come to the difference between thin prep and sure path. Okay, in thin prep they use filters. Okay, when you see the procedure, you will know that we use filters, and in sure path method, we use precipitation. Okay, as a mechanism. Both are semi-automated machines. The preservative fluid which we use in thin prep is methanol based, and in sure path it is ethanol based. And then one very important differential thing is the diameter circle of the slide spread in on the slide. Okay, the diameter or circle of the cell spread on the slide is 20 millimeter in thin prep and 13 millimeter in sure path. Okay, so sure path it is small S. Sure path, it is smaller diameter, and in thin prep, it is bigger diameter, that is 20 millimeter, and in sure path, it is 13 millimeter. And centrifugation is required in thin prep, whereas in sure path also it is required. Storage, you can store for 2 years in thin prep and 3 years in sure path, and the storage degree and weeks and all are written. Dispersion technique, which is the first step in both the liquid-based cytology procedure. For that, we use vortexing, and here we use vortexing as well as syringing. And sampling device which we usually use cervical broom in the sure path thing. And in thin prep method, we can use broom or spatula or endocervical brush as well. Anyway, all the cells which are 100% of the cells that are going to be collected are going to come in the preservative fluid. So brush or the instrument isn't a much difficulty thing in thin prep. So these are the methods that we use for thin prep and sure path. In thin prep, what do we do is first cervical brush is dipped in the methanol based preservative fluid. Okay. And then we do vortexing, that is, cell is centrifuged and then it is allowed to suspend in the fluid, disperse and suspend in the fluid properly. And then we use a filter, it is placed over the centrifuged suspended tube, and the filter is rotated and you apply a negative suction along with it. Okay, so when the filter is rotated and then negative suction is applied, the cells get stuck onto the filter and the suction pressure is adjusted in such a way that only a thin layer is formed, okay, over the filter, and is also rotated to get a proper thin layer. And then the cells that are stuck onto the filter, as much as its diameter, only that much only cells are taken, not that all the cells are taken into the filter. Okay, that is why we have the remaining cells inside the fluid itself. So as much the diameter and as much the thin layer is formed, that much filter is sucks the cells and then it is released onto the slide. And this is how we make the thin prep slide. Next, in the sure path method, firstly, vortexing is done. That is the slide, the brush which is put inside. Okay, it is centrifuged first properly so that the cells get dispersed, and then disaggregation is done. Disaggregation, if there is clumps still present after the vortexing, we use a disaggregator and you release the clumps so that there is homozygous cell dispersion. And then we introduce it into a sedimentation tube and we put into it a density gradient fluid. Okay, a density gradient fluid is added onto the solution and then you do sedimentation so that it separates according to the density gradient. The cells will get separated according to the density gradient, and then the sediment is, after the sedimentation procedure, the precipitate that is formed, that is the cells, will get settled onto the slide, and that is how you get a 30 millimeter diameter sure path slide. So the system that we use for reporting cervical cytology is 2014 Bethesda system, which is the latest edition. So what is the specimen adequacy? Okay, each and every word counts. Well preserved, well visualized squamous epithelial cells. So you need, in conventional smear, 8,000 to 12,000 well preserved, well visualized squamous epithelial cells. If it is a liquid based cytology, either sure path or thin prep, the adequacy criteria is 5,000 cells that are well preserved, well visualized squamous epithelial cells. Okay, well preserved means, I said no, if the conventional smear is coming without a formalin, you will get air dried artifact. That is not well preserved cells. Well preserved is which slide which has come in proper formalin. That also the slide is placed into the fluid just as soon as the pap smear is taken. Not that it is allowed to be kept outside for long time, then it was put into the fluid. Okay, so that how you will get a well preserved. Well visualized means a squamous epithelial cell which is not obscured by blood, mucus or inflammatory cells. That is well visualized cell. So you need well preserved, well visualized 8,000 to 12,000 squamous epithelial cells in a conventional pap smear to call it adequate. Okay. Now, this criteria is not applied in certain conditions, that is, especially when there is post therapy. You all know that after chemotherapy and radiotherapy, the cells do decrease. So, we have the Bethesda system has kept a cutoff of 2000. And then in post-menopausal cases also it is the same. That is, after menopause also because of atrophy, the cell count decreases. And in post-hysterectomy also you need 2000 cells only. And okay, it is easy to tell that is 8,000 to 12,000. We won't be sitting and counting 8,000 cells to see whether it is adequate or not. So how can you do is like conventional smear, if you're taking a forex field that is in the low power, if you're seeing 150 cells per field in all fields, okay, or you can count 500 cells per field in 16 fields, or you're counting 1,000 cells per field for 8 fields. Okay, if you are taking 150 cells per field in low power, then it should be present in all the fields uniformly. Then only you can call it adequate. If you are taking 500 cells per field, like that you count only for 16 fields. If there is 500, then it is adequate. And if you get 1,000 cells per field, then after counting 8 fields, you can tell it is adequate. Okay. So the lesser number of cells, you need more number of fields to tell that this is adequate. That is what it is said. And then in sure path method, you need, in the 40x, that is in the high power, you need 11 cells per field. And in thin prep slides, you need 4 cells per field in the high power itself. Okay, the thing which I want to tell is now you can see in 11 cells per field in sure path and lesser number of cells in thin prep. Why? Because the diameter is more in thin prep. So when the diameter is more, obviously there is um, more cells spread out. So you need only 4 cells per field. But in sure path, it is only 13 millimeter diameter, so you need more cells, that is 11 cells per field. Now, endocervical or transformation zone component. Okay, before in the previous Bethesda system, it was a criteria to include endocervical or transformation zone component, that is either endocervical cells or squamous metaplastic cells, to tell that the pap smear is adequate. But now in the Bethesda system, it has been removed because in some of the studies, it was found that uh, people who doesn't have endocervical or transformation zone component have a higher chance that there can be high grade lesions or squamous intraepithelial lesions. So the slides which they used to call as inadequate because there is no endocervical component may be a chance that we are just discarding, or a slide which there is a probability that the patient is having a premalignant lesion. Okay, so to avoid that confusion, Bethesda has removed that there should be endocervical or transformation zone component. It doesn't mean that every endocervical every slide which doesn't have a transformational zone component can be premalignant. Just that some studies showed that there is a more chance that they might be having. Okay, so but Bethesda has said that presence or absence should be reported. Okay, if it is present, also you should say. If it is absent, also you should say that endocervical component is absent. So if it is not present, obviously it is considered that it is absent only if it is not present written in the report. But if it is present, then obviously it should be present, and ideally it should be written that it is absent also. That is endocervical component is absent in the slide. And then to tell the endocervical component is present also, you should need at least 10 well preserved, okay, well visualized obviously, endocervical or squamous metaplastic cells. Okay, squamous metaplastic cells are also present in the transformation zone itself, and they can be present singly or in clusters. And now you should know this obscuring factors. Okay, when do we call a slide unsatisfactory? Due to obscuring factors. So if there is more than 75% of the squamous cells are obscured by inflammatory cells or blood or lubricant or discharge, then you should call the slide as unsatisfactory for evaluation. Once again, more than 75% of the squamous cells are obscured by the inflammatory cells or blood or lubricant or discharge. As you can see in the figure here, you can see only inflammation. Background mein there is squamous cells and all, but you cannot see because of the obscuration of the inflammation. And it is more than 75% of the squamous cells, not 75% of the slide. Okay, not more than 75% of the slides. The squamous cells that were present, more than 75% is obscured, then you call it as unsatisfactory for evaluation. If the cellularity is less, still it is unsatisfactory for evaluation. Cellularity is there, but it is obscured, that is also unsatisfactory. But provided there should be no abnormal cells identified. Okay. See, I said more than 75% is obscured, but maybe in that less than 25% also, if you see abnormal no, sorry, abnormal cells, then you should consider it adequate. Okay. You are going to report that atypical cells. For that, you will call the slide as adequate. But if there is no abnormal cells, then by definition, this is unsatisfactory for evaluation. And if the obscuration is 50 to 75 percentage, it is not unsatisfactory, but then you will mention that the cells are partially obscured, okay, in the report. In thin prep, the thin prep method, there is that key if you are seeing so much of bloody specimen in the first slide, you can reprocess the slide with using dilute glacial acetic acid wash. Okay. If you know the specimen is bloody, then you can process it with dilute glacial acetic acid wash. Then the obscuring factor will be decreased to a very less rate. So, this line is important that any specimen with abnormal cells, that can be atypical squamous cells of undetermined significance or atypical glandular cells, or worser. Worser means you are getting L cell, H cell, etc. Then by definition, they are satisfactory for evaluation. That is why I said ki obscuring factor is there, but there shouldn't be abnormal cells among the visualized cells. So if there is no abnormal cells and then there is this much obscuring factors, then you tell it is unsatisfactory. But if there is some abnormal cells, you are going to report the slide, and then then you will obviously tell it is satisfactory for evaluation. If it is not satisfactory, then the report is also not valuable. That is why we use it like that. And then this is also important that nothing should be reported with respect to intraepithelial lesions or neoplasia in interpretation section for unsatisfactory specimen, cause by definition they are unsuitable for evaluation. That means obscure slide, it is unsatisfactory by evaluation. It is not at all suitable for evaluation. So in such cases, you are not supposed to comment on the intraepithelial lesion or neoplasia. You just say it is unsatisfactory for evaluation, repeat the smear. So now we come to the topic proper, that is non-neoplastic cells. And it's almost half an hour. Okay, so this is a term which we all know, that is negative for intraepithelial lesion or malignancy. Because all these non-neoplastic cells you will see mostly in this case NILM, and this is the most common diagnosis that we give for pap smear. And if you don't know how to identify ATPS, still you will give NILM. Okay, so it is important to study pap smear reporting. So to identify atypical cells, first you should know how the normal cells are. So coming to the normal cells, squamous cells, as you see in the cervix, has four types of layers. The lowermost is the basal cell layer, then comes the parabasal layer because it is adjacent to the basal layer, and then there is the intermediate layer, then there is the superficial layer. Okay, and then as you go above, this is the immature cells, and as you go above, it is maturing and maturing. Okay. So superficial cells are the most mature cells. They will be having keratin. And then as you go above, the cytoplasm is increasing and it is becoming abundant, and the nucleus is decreasing and decreasing and it becomes pyknotic. Okay. So high NC ratio is most in the basal cell and it is lowest in the superficial cell. So according to the cycles, how it is that key in endometrium there is stratum, basal and spinosum, etc. In the same way in the cervix also there is stratum, basal and then stratum parabasal, and then there is stratum spinosum in which you get the intermediate cells, etc. So during the beginning of the cycle, that is when there is menstrual shedding, that time you will see mainly the intermediate and parabasal cells. Okay. And then during the mid cycle, that is in the proliferative phase, there is increased estrogen secretion. And because of that, there is a lot of proliferative activity. And then you will see the superficial cells in abundance. And then again in the secretory phase, when there is progesterone, then you will get predominantly intermediate to parabasal cells. So this is how a superficial squamous cell looks like. So it is the outermost layer, and as you can see, the cells are polygonal and it has abundant eosinophilic cytoplasm and a pyknotic, highly condensed nuclei. Pyknotic means almost dot like in the low power. Okay, so and the nuclear size is 10 to 15 micrometer square, 10 to 15 micrometer square. And then you can see the keratohyalin granules in the cytoplasm, or you can also see the light brown glycogen content, okay, in the superficial cells. Okay, so why there is glycogen in the cervical cells? Because you know there is lactic acid bacilli in the vagina. So what happens is that during after puberty, the superficial cells that come, okay, pre-pubertally, if you take also, you will get only basal layer of cells. Okay, when there is estrogen and production of estrogen, then only you will get the proliferation and then superficial layer of cells. So in the superficial layer of cells, you will get this light brown glycogen secretion, and the lactic acid bacilli feed on these glycogen. They convert it into lactic acid, and that is how there is acidic environment that is maintained in the vagina or the cervical area. Okay, so why there is acidic medium? Because during the sexual intercourse there is high chance of getting infections. So the acidic medium or acidic environment is protective against the infection. So that is why you have lactic acid bacilli also there. So there is light brown glycogen content in the superficial cells, and then in the proliferative phase you will get mainly superficial squamous cells, and when there is also irritation or infection for the patient, that time also, like in cervical prolapse, cervical and uterine prolapse samples also, because of there is constant irritation that the cervix is exposed outside now. So according to the clothes and all things that constantly come in touch with the cervix, there is constant irritation. Because of that, you get keratinization and then extensive proliferation of the cervix. That time also you will get superficial squamous cells. And then intermediate cells is the second layer, which is deeper, and they are polygonal cells as well, and then they are elongated nuclei with a fine granular chromatin and a longitudinal nuclear groove. And the size is little about, first one I said 10 to 15, and this 35 micrometer square. Okay. Should note that the cytoplasm is still very abundant and very flattened and diffuse, uniform. It's like chapati we have flattened on a dough, okay, by an inexperienced person, which is not at all very round. Okay. So I just meant to tell, means it's like very diffuse and uniform dense. Okay, it's not at all dense, it is uniformly stained cytoplasm, and then you can get a proper nuclear groove, and the nucleus is little larger than the pycnotic nuclei. Okay, if you go to high power only, you will appreciate the groove. If it is a very experienced person, you can see it in the low power also, the group. And then intermediate cells are the reference size for other cells, okay, intermediate cell nuclei especially. And then it is the progestational agents or the progesterone that mainly causes intermediate predominant smears, that is especially in the secretory phase of the menstrual cycle, and during pregnancy also you will get intermediate predominant smear, and it is seen in the secretory phase. Now, coming to parabasal cells, they are usually seen in the atrophic or postpartum or postmenopausal state. Okay, and these are the deeper layers of the cervical squamous epithelium. They have moderate dense cytoplasm, and they have oval nuclei, higher nuclear cytoplasmic ratio, as you can see, and the nucleus is 50 micrometer square. Okay, 50 micrometer square, and they have fine chromatin. Okay, in absence of any hormone, absent in hormonally mature epithelial specimen. Okay, what does it mean is like hormonally mature, that is in a menstruating female, when it is hormonally mature, that is when there is estrogen and progesterone production, you should usually see no parabasal or very less parabasal cells. Okay, that is in a menstruating women, other than it is in postpartum state. So if usually you see parabasal in postmenopausal only, or otherwise if you are seeing parabasal cells, then there is some pathology, that is there is a very deep infection, or you are seeing it in the, as I showed, you are seeing it in the menstrual phase or almost to the end of the cycle, because that stage you are not going to see the superficial and intermediate are almost shed away in the menstrual cycle, and that time you can get the parabasal cells, because that time all the cells are shedding, and that time you will get parabasal cells also to certain extent. But in hormonally mature, that is when there is hormone production, estrogen and progesterone in our body, then you should usually not get parabasal cells in much. But if there is very deep infection, I'm telling, if there is very deep infection, the superficial and intermediate cells have already been gone, and then there is irritation also, because of that parabasal cells also can come into the smear. So as you can see, parabasal cells and the intermediate cells, if you compare, you can see there is a cytoplasmic heap. Okay, it is compared to a saucer with a central nuclear heap. Okay, a saucer with a central nuclear heap. You can see a perinuclear halo like this, which is forming. If you are seeing from a sideways view, you can see there is a sloping edge like hill. That is the view of the parabasal cell, that is called, okay, a hill with a sloping edge. You can see how well defined the cytoplasmic borders are, round to oval almost, and see the cytoplasm here. There is a non-uniformity, that is, it is dense here and it is not at all dense here. Here there is no, there is very almost very uniform cytoplasm, okay, and very flattened kind of appearance. And you can see obviously the nuclear size is more. This is 35 micrometer square and this is 50 micrometer square. So intermediate cell, what you're taking as reference is you compare the nucleus, okay, to say whether it is superficial, it will be lesser, and then the other cells will be having a higher nucleus compared to the intermediate cell. And then now you can see this is a group of squamous cells. In this basal, I didn't mention because basal is like parabasal cell only with more high NC ratio. Okay. So you can see these cells are basal cells which are having higher NC ratio. And then you can see the cytoplasm is much more less and nucleus is much more high. And these are the parabasal cells. You can see the cup and saucer. No, sorry. This is a saucer with nuclear heap, and then you can see some perinuclear lightning because of the density gradient in the cytoplasm. And then these are parabasal cells. You can see there how much round to oval cytoplasm is defined. And then you can see these are intermediate cells. Okay. So these are intermediate cells, and I can say it is not exactly parabasal also. So the cells that you are seeing here, these are parabasal to intermediate cell, if I would say, because you can see these are the pycnotic nuclei cells, which are little orangeophilic because of the keratin component. You can see keratohyalin granules as well. Okay. Now coming to look at these cells, they are becoming round to oval, but their high NC ratio is just increasing only. These obviously have high NC ratio, but this nucleus is almost intermediate between the superficial and the parabasal cells. So it's not that the cells read the textbook and come. So you can get stages like which are almost superficial to intermediate, or intermediate to parabasal, or parabasal to basal. So it's according to your discretion, the experience, that you can count it in intermediate or parabasal or superficial. Okay. So with experience, you will understand where to classify. But for time being, if they are not atypical, you can put it in some category which is nearby. That is either intermediate or parabasal. So now how endocervical cells are seen. Endocervical cells can be seen in classically two appearance, that is honeycomb pattern or a picket fence appearance. Okay. So as you can see in honeycomb appearance, because the nucleus is very round to oval, and then the prominent thing is the cell membrane. Okay, the cell membrane, if you see in the slides, it is very prominent that it gives a honeycomb pattern. And then why you are getting a pattern? Because see, these are columnar cells, okay, which have a nucleus which are present basally, and all the mucus is present in the other pole. Okay, this is called the cell polarity. That is, nucleus is present in one end and mucus in the other end. Suppose in this end where there is nucleus, you are giving a cut like this. Okay, then you see at the slide from this part of the slide where there is only nucleus, okay, you will get this appearance. Okay, that is a honeycomb appearance. And you can see how columnar the cells are, that is endocervical cells. So the nucleus size is 50 micrometer square, which is almost the same as the parabasal cell nuclei, but they have fine granular chromatin and there can be small nucleoli. Okay, small nucleoli can be present, which are usually not seen in the parabasal cells. Cell membrane will be very prominent. In parabasal cells also cell membrane is defined, but I would say in endocervical cells they are more prominent. And after all, you will be differentiating a squamous cell from a glandular cell when you are differentiating endocervical and the parabasal cell. So coming to endometrial cell, how does endometrial cell look? They have smaller nuclei, that is 35 micrometer square, almost intermediate cell nuclei you have to compare. Endometrial cells have a nucleus which is almost same as the intermediate cell nuclei. Obviously, they have high NC ratio and they have scant cytoplasm as you can see, and they have monotonous nuclei. Okay, monotonous nuclei means almost monomorphic also, so that you don't think there is any atypia in the endometrial cells. So endometrial cells sometimes they can present as exodus ball also. So when there is exodus ball, there is exfoliated endometrial cells that form a dense aggregate, and the endometrial cells have glands as well as stroma. So in the central part there is stroma and in the peripheral part there are glandular cells. Sometimes they can show degenerative change, that is very blue color appearance, and usually this exodus ball appearance and endometrial cells are seen in menstrual cycle day 6 to day 10. Squamous metaplastic cells, that are the cells which are making the transformation zone component, okay, along with endocervical cells. So squamous metaplastic cells, they can show a wide range of morphology. They can either be undifferentiated small round cell like this almost, to a highly differentiated superficial or intermediate like of cells. Okay, there can be superficial or intermediate like cells also with abundant cytoplasm, and then spidery like cytoplasmic processes. If you get cytoplasmic processes very well and good, you're lucky. It's not always present that you can see cytoplasmic processes. It depends on the staining technique also, and it's not that the squamous metaplastic cells should always show their process outside. So sometimes like these cells are seen, then you will have to know they are squamous metaplastic. So you compare the nuclear size with intermediate nucleus and then see it is squamous metaplastic, so that you can differentiate it from the parabasal cells. That is why intermediate cell nuclei are taken as reference. Okay. And the round to oval cell nuclei is 50 micrometer square. Sorry, it's not with the intermediate nuclei, they are with the parabasal nuclear size. Okay, 50 micrometer square, and they have fine chromatin. But you can understand one thing is that the uniformity in the cytoplasm is different from the parabasal cell, obviously. And the shape also, sometimes because of the cytoplasmic process, they might be having not a proper shape, and but parabasal cells are obviously almost round to oval, and they have well defined cell membrane also. Stimuli is that when does squamous metaplasia occur? In endocervix, metaplasia occurs when there is infection, inflammation, or when there is trauma. So squamous metaplastic cells have nucleus of 50 micrometer square, same as endocervical cells. Okay. Endometrial cell nuclei is same as intermediate. Squamous metaplastic endocervical cells and parabasal cells almost have same size of nuclei. So you should be able to differentiate between these. You can see one is columnar cells, obviously, the other two are squamous cells, and the cytoplasmic features are the one thing which you have to differentiate, and then you have to look at the processes as well. See, if there is a cell group present, then you should see at the periphery of the cell group what type of cells you are getting. You are getting a parabasal kind of architecture or a metaplastic or endocervical kind of architecture. So this is a picture which I want to show you, that is, see you, what do you think when a squamous metaplasia occurs? When I ask students, I have heard some answers like the columnar cells get converted into squamous cells. So this is not the scenario what is happening, okay? So actually, normally in the cervix, there is endocervical layer. Then there is a reserve cell layer, which you can, if you can see properly here. So there is a basement membrane over which there is endocervical cells. Between this endocervical layer and the basement layer, there is a reserve cell layer. Okay. The reserve cells are usually present. Okay. They are the cells that undergo change to become squamous metaplasia. So these are like stem cells. They can either differentiate into columnar cells or they can differentiate into squamous cells. So when metaplasia is occurring first, reserve cell hyperplasia occurs, then they get converted into squamous differentiation, then the endocervical cells just slough off. Okay, that is why you see later on only squamous cells. That also first you will see immature squamous metaplasia, and then later on they will get matured and form mature squamous metaplasia. Then it will be difficult to differentiate the mature squamous metaplasia from the normal ectocervix. Okay, so you might see a transformation zone shift there, but then if below the squamous metaplastic cells, if you're seeing endocervical glands, okay, then you should know that is a metaplastic stage. So here you, as you can see here, you can see the endocervical glands. This is like, I should say, some little rare kind of slide that you will get. And it is a very beautiful picture from the Bethesda, that endocervical glands you can see. And then here is the reserve cell layer, which is proliferating, okay, which is undergoing hyperplasia and it is getting converted into squamous differentiation. That is why you're seeing endocervical above and reserve cell hyperplasia here, and which is becoming squamoid. Okay, this is also little rare that you cannot see properly. Normally, you don't get slides which are showing such reserve cell hyperplasia. So now coming to some changes. So what is keratotic cellular change? Okay, keratotic cellular change are like in, if you're seeing skin slides, you know there is hyperkeratosis, parakeratosis, etc. It is the same thing that you're seeing in keratotic cellular change, that is hyperkeratosis, parakeratosis, etc. So it is a protective or it is a reactive phenomenon. Okay, and sometimes it can be HPV induced as well. Okay, so there is hypermaturation you're telling, that is more keratin production or parakeratosis, etc. So there is prominent keratohyalin granules that you can see, and there will be orangeophilic cytoplasm. And orangeophilic cytoplasm is because there is more keratin component. As you can see here, there is so much of orangeophilic cytoplasmic superficial cells. So this is hyperkeratosis. Sometimes you can see ghost nuclei because there is no nuclei, there is only uh, ghost of the nuclei. Okay, so these are hyperkeratotic cells, and why nuclei is not there? Because it is matured. Okay, so usually in keratin layer you won't get nucleus, and when there is nucleus in the keratin layer, then it is called parakeratosis. So how you are identifying parakeratosis is that because it is, see, very orangeophilic cytoplasm, that means it is a keratin layer. So in a keratin layer, if you are seeing the nucleus, then it is a more chance that you are seeing a parakeratotic cell. So these are just protective or reactive phenomenon you can see in uterine prolapse also. And then there is tubal metaplasia. Tubal metaplasia is the metaplasia of the endocervical cells into tubal-like. Tubal-like means fallopian tube-like. So what is there in fallopian tube is ciliated cells. So when the endocervical cells, they have cilia, or they might be having terminal bars. Terminal bars means like this, the columnar cell. If you are seeing the terminal bar and the cilia, then it is called tubal metaplasia. They can be either columnar cells properly you will see, or there may be forming a little syncytium-like appearance. It is a pseudo-stratified endocervical cell group you tell. They'll be having higher NC ratio, but you should not uh, think they are atypical kind of cells. Okay, they are just tubal metaplasia, mainly the cilia or terminal bar is the one you have to look for. Next is atrophy. And atrophic slide here, one side I have shown histopathology and other side I have shown the same pap smear. Okay, see how the parabasal cells are. Okay, there are darker basal cells also. Then you can see the parabasal cell real how much of high NC ratio they have. Okay, and these cells are seen mostly as a syncytium also, so you cannot differentiate the cytoplasmic borders at times. But then see at parts you can see here there is little less NC ratio, that is they are parabasal cells. If you are not seeing, if you are seeing high NC ratio, they may be basal cells or atypical, but at periphery you just look at the cells. Okay, and these parabasal cell sheets, okay, they can have round to elongated nuclei. When they are too much elongated, you shouldn't confuse it for granuloma. Okay, so they can be round to oval to little elongated kind of nuclei, and they can form sheets, or they can be even singly dispersed. Okay, so these are atrophic cells that can be singly dispersed, and sometimes you can see the nucleus is disintegrated karyopexis like, and you can see blue blobs. Blue blobs means blue color, very dense cell. Okay, they are because these are cells that are degenerated, because in atrophic smear you can see many degenerated cells where nucleus is degenerated or the cytoplasm including can be degenerated. When it gets degenerated, it will be more blue in color. Okay, more basophilic in color. And then background, at times you can get granular debris, which is common in atrophic smear. Okay, because the cell is disintegrating or atrophic. Okay, so the debris of the cell, maybe you will confuse it for tumor diathesis. Already the parabasal cell layer looks with high NC ratio. Over that, if you see granular debris in the background, this is a liquid based cytology, you shouldn't confuse it for tumor diathesis. Okay, look at the age and then clinical history, and then you go for the diagnosis. And at times you can see so much of inflammation also. That time you should think about atrophic vaginitis. Okay, so here there is singly dispersed cells and there is so much of inflammation surrounding it. Sometimes you can get pseudo parakeratosis, okay, in an atrophic smear. Why pseudo parakeratosis? Because you can see so much of orangophilic cytoplasmic cells and they have very good nuclei also. So it stimulates a parakeratotic cell-like appearance. So it is called pseudo parakeratosis. Okay, so this is atrophic vaginitis smear, and I would suggest, okay, my examiner in my exam had said ki if it is an atrophic smear and if you're getting so much of inflammation, it is important that you mention it as atrophic vaginitis, because then the patient will be treated for it with hormone replacement therapy, etc. because it has so much of symptoms like drying, itching, and all those things. And in some cases in pap smear, you can get these multinucleated giant cells that are consisting of histiocytes or macrophages. Okay, histiocytes are tissue macrophages. So you can see histiocytic collection. So this is common, okay, if there is inflammation or in atrophic smear and all, you can get, okay. Thing is that you should not confuse it for granuloma. And I'm not telling that granuloma won't be present in pap smear also. In extremely rare cases, when if you are seeing there is TB in the cervix, then only you will get granuloma. So for that also you need a very good clinical correlation. So when you get such a smear, don't be afraid. I did an extensive study when I got such a kind of thing in the initial days. So they are not granuloma, they are just multinucleated histiocytic collection. Then you should know reactive reparative changes. So when there is reactive reparative change, that is especially when there is inflammation, too much inflammation or infection. And after therapy and all, you can get nuclear enlargement. And the characteristic thing is vesicular nuclei with prominent nucleoli. There can be binucleation cell and multinucleated cell. Thing is, they will give a school of fish appearance. You can see as in here a streaming of the cells and interdigitation of the cells. Okay, and then you will see taffy pull cytoplasmic appendage. Taffy pull means how a toffee, if you pull and you see how it is in a stretched manner, in like that, the cytoplasm is seen as a taffy pull appearance. Okay, and then you will get slight perinuclear halos and then intracytoplasmic. Inside the cytoplasm of the cervical cells, you will get neutrophils. Okay, these are reactive or reparative cellular changes. But you should note that these nucleus enlarged, but they are not showing any irregularity of the nuclear membrane. Okay, there is usually no nuclear membrane atypicality or hyperchromasia. And then these are the perinuclear halos that you can see in an inflammatory smear, and these are reactive or reparative change, and they are not coilocytic change. Okay, I repeat, that is not coilocytic change. Why there is perinuclear halo? Maybe because the protein is produced from endoplasmic reticulum, which is getting activated or concentrated in the perinuclear region, which is giving a halo-like appearance, and it is because it is a reactive change in the cells. And now during radiation or after radiotherapy, you will get such kind of very bizarre looking cells. There can be binucleation, multinucleation. They have abundant cytoplasm, or maybe they can have little less cytoplasm also, but they will be having very polychromatic cytoplasm, that is blue and yellow, red, all the mixture type of color pattern you will get. And they will be having a vesicular nuclei and prominent nucleoli, and you can get vacuolated cytoplasm as well. And then reactive cellular change in IODs, like you can see so much of vacuolated cytoplasm and vesicular nuclei and prominent nucleoli. And the vacuolated cytoplasm is so much that it gives a signet ring kind of appearance. So you should elicit the history of IOD when you see such a kind of cells. And you should also rule out herpes simplex infection, because there also you can see like this vesicular cells, no, vacuolated cells. So during the phases of the menstrual cycle, in menstrual phase, if you're taking a pap smear, you will obviously get blood and menstrual debris in the cervical sample, which you don't want, and it is difficult to assess also. And then in proliferative phase, as I said, because of the estrogen content, there is very high proliferative activity. And because of that, you will see a large amount of superficial cells, okay, in the sample. And then they will be having mostly clear background. And in secretory phase, what happens is that because of the progesterone and estrogen combined effect, there is maturation of the squamous epithelium, and the parabasal cell becomes intermediate layer. Okay, so in secretory phase, you will get predominantly intermediate layer cells, and then you will get so much of lactobacilli and cytolysis. As I said, in estrogen, first there will be so much of glycogen. Okay, then the lactobacillus will spread in the secretory phase, and then they will convert the like glycogen to lactic acid, so that the environment is now acidic, and then you will see so much of cytolysis. So this is a smear which is seen in the uh, secretory phase, you can see there is so much of lactobacillus proliferation. It is normal only, don't tell it's abnormal proliferation of the bacteria. And you can see so many bare nuclei and many cytoplasmic fragments. Okay, these are cytoplasmic and nuclear cellular debris, you can call it, okay, in the pap smear. And you can get intermediate cells also. So this is not tumor diathesis or something else which you should be confused in such cases. So lastly, I have a question for you people. What are these cells? These are navicular cells. I want you to go and read and comment, when are these cells seen in the pap smear? Okay, a simple task. At least you should open the book to know what is happening. So, the first part of my pap smear reporting I am ending here. So, thank you for your patient listening. Kindly do like, share, and subscribe my channel and comment your questions or doubts that you have. And if any topic you want me to discuss, that also you can put in your comment. And I take this opportunity to show my gratitude towards respected Ritu Nair and David C. Wilbur, who has contributed the Bethesda 2014 Springer book. Okay, so thank you all so much.